I'm a social worker and a member of the Geri Echo Hub team. I'd like to introduce our other Echo team members who are all here that are willing to teach and share our collective experience and wisdom with you. But before I do that, just a kind reminder that this CME activity is jointly provided by the Queens Medical Center and Jabsam Department of Geriatric Medicine. So joining our team is our advanced practice nurse, Courtney Nunokawa, our pharmacist, Chad Kawakami, our psychologist, Dr. Lucas Morgan, and our geriatrician, Dr. Rita Bell Fernandez. As a reminder, evaluations are required for your CMEs and for social workers, your CEUs. You can find the evaluations by following the link in the chat or at any time on our website and email advertisement. We are currently offering also continuing education for the nurses and physician's assistants. We can offer certificates of attendance for CNAs and students. Your comments are very important and useful for our planning future programs. So kindly complete the evaluations. Here at ECHO, we want to emphasize that this webinar serves as a forum for mutual teaching and learning from experts and from each of us on the front lines. As our motto goes, all teach, all learn. So it will take all of us to create a community of learning. How our format for this afternoon will play out is it consists of a short lecture from our expert presenter and then open comments from the expertise of the ECHO Hub team. You as attendees, we appreciate your comments, questions, even case examples for discussion. We also, besides inviting you to share geriatric cases, want you to know that anything else that is relevant to the presenter today. Lastly, we ask that you keep case discussions HIPAA compliant. This includes not sharing the patient's name, birthday, address, and so on. We learn best from our patients and our clients. They are our best teachers. So today it gives me great pleasure to introduce our distinguished speaker, Dr. Cor Liu is director and the principal investigator for the Alzheimer's Research Unit, Memory Disorder Center with the Foundation of Hawaii Pacific Neuroscience. He's also a clinical professor of neurology at the University of Hawaii John A. Burns School of Medicine. His team serves 20,000 patients from all of the Hawaiian Islands, making global impact with more than 40 clinical research projects undertaken and the over 50 residents, medical and research students on rotation with him. We just heard on the news about the new Alzheimer's disease drug approved by the FDA called Leqembi. Dr. Lowe was part of that groundbreaking research, and it's so timely that we have him as our honored guest to speak for the July Geriatric Echo Clinic. Welcome, Dr. Lowe.
Thank you, Sarah, for having me, and thank you, Dr. Fernandez, for having me. I'm going to go ahead and share screen here so we could bring up the aloha. Good afternoon, everyone. And hopefully you can see my screen there. Okay, and go down here and oops. Okay, you getting a headache yet? Okay, are you seeing the screen or are you seeing a double screen there?
We can see the screen, Dr. Lowe.
Okay, thank you so much. Sorry for the technical difficulties, and thank you, Dr. Fernandez and Sarah, for the nice introduction. Let's get right to it. Sorting out myth and facts for Alzheimer's new treatments, and this is my disclosure. And if anybody else wants to find me, tell them to come and talk to me. So we have several objectives today. Obviously, the big thing is to talk about lecanemab that was approved last week by the FDA, and how is it different from aducanumab or aduhem? And obviously, everyone is interested in knowing about ARIA, the amyloid-related imaging abnormalities, which I'd like to shed some light. And the third thing is, what is lecanemab indicated for, and who would not be suitable? And that's really important to know. And then we'll just quickly look at what does the future looks like as well. Okay, so here we are, looking at why all the excitement and what's so big about this news. Well, if you're as old as me, remember the days of, I remember I started my training with drugs like Cognex or Tacrin. I know most of you don't remember that, but I'm old enough to remember that. And I tried actually to Google what Cognex does. Cognex is actually a IT company now, so it doesn't even exist. Tacrin went out of use in 2013 because of liver toxicity. So the fact that this is catching a little bit of news because lecanemab or Leqembi is the first what we call disease-modifying treatment that targets the biology, not just targets the symptoms like donepezil, Exelon, resident Amanda, or what have we. The way that I explain it to my patient is that, we can either put you on something that treats a symptom, or put you on something that treats a disease, so whether it's disease modifying arrest or disease modification deceleration, we're obviously working on those. So let's go right ahead. Lecanemab was approved last week, July the 6th. So how is it different from aducanumab? And what is it anyway? So the way that I explain it to my patient is that they're both kind of like cousins. They're both monoclonal antibody, and they just works on the same pathway. They just work at different point. So if we remember that this is our plaque right here at the end product, and we start with the amyloid precursor proteins in the neuronal membrane. So aducanumab right here works at the second phase of the aggregation, while lecanemab works at the protofibrils bind at the elongation phase. So they kind of like works next right to each other, but they're just blocking the pathway at different points. Does that matter? Sure, it does, because there are some differences. So without going into too much detail, so lecanemab was approved based on the phase 3 Clarity Band study, which our site was involved in, Site 2109, Hawaii Memory Center. Busy slide. So what do we need to look at? Just a few things. How many patients were involved? 1,795 patients. What kind of patients? MCI and mild Alzheimer's disease. MMSE scored 22 and above. So they only used one dose, 10 milligrams per kilogram. How often it was given? Bi-weekly, every 2 weeks. Okay. And how is it different from aducanumab? Aducanumab involved more people, 3,285. This is on both the phase 3 Emerge and Engage trial. And same patient population, MCI and early Alzheimer's, but the MMSE is a little bit different, 24 to 30, and we are still actively involved in Envision trial, the phase 4 trial with Site 1005, Hawaii Memory Center. So did they work? What are the results, and did they work? So a couple of things. So what did we measure? Obviously, we want to measure, did it help them with the memory? So we measured something called CDR-SB, or Clinical Dementia Rating, sum of boxes. CDR-SB is just 18 points scale measuring cognition, memory, orientation, judgment, problem solving, and function like community affairs, home, hobbies, and personal care. And so let's look at in aducanumab. So remember, there was 2 doses, low dose and the high dose. So this is the primary endpoint, CDR-SB. Aducanumab had 22% slowing down the cognitive decline compared to the placebo. Okay, and obviously the low dose is not as impressive, only 15%, while lecanemab had 26% less decline, cognitive decline compared to placebo. Okay, and remember that lecanemab only had one dose, but they did test it at biweekly and monthly, and 10 milligrams biweekly shows 26% less decline. So what else did they measure? So in these studies, we usually like to measure amyloid load. So we want to see if it made a difference. Did it reduce the amyloid, obviously? So we can either measure it by amyloid PET scan or CSF amyloid. So in Hawaii, we measured the CSF amyloid because we do not have amyloid PET scan. We are sending our patients to California for amyloid PET scan, currently in our other studies. So in aducanumab, the reduction in the amyloid load was 75%, while lecanemab, the reduction in the amyloid load was 93%.
Dr. Liao, we have a question
Yes.
from our attendees. Since we're on this slide, if you can comment on this slide on the diversity of the study group, like what was all these inclusion criteria? Was imaging required? And how do you understand what may have been the heterogeneity among the study group?
Yeah, no, good questions. So let's address the diversity first. On both let's talk about the lecanemab. I'm imagining that you're asking about lecanemab. Out of 1,795 patients, there were 7 Asians and 1 Native Hawaiian population, which we are very proud to say that they are from our side. So it is, and I believe there were about 20 to 25% minority patients that were represented in the study. So the patient have to have MMSE 22 and above. It has to rule out all other criteria like vascular dementia. Those are ruled out by MRI, and you can't have stroke or anything else. And then obviously the crux of the inclusion criteria is the amyloid. You have to have amyloid positive. So the patients that will enroll have to have a CSF amyloid positive. Yeah, hopefully that helps. Okay, and let's move on because Dr. Fernandez gave me 30 minutes. So, all right. So this is things that I want to spend a few minutes on ARIA, or what we call amyloid-related imaging abnormalities. What do you need to know about ARIA, and what is it? When do you need to be worried about it? So is it safe? What are the side effects? So ARIA is probably something that you need to be aware of. It's called amyloid-related imaging abnormalities. It happens in about 28% in the aducanumab tested patients and 17% of lecanemab tested patients. So what is ARIA? ARIA is divided into 2 groups. You can have ARIA E for edema or ARIA H for hemorrhage. So over here, the top 2 MRI, we showed some ARIA edema. You can see some signal changes, some vasogenic edema in the posterior temporal occipital area. And also on the diagram B, you can see some south side effacement. So there is some edema. We think that ARIA edema is from inflammation, due to inflammation. And then ARIA H is ARIA hemorrhage. At the bottom, you can see some micro, usually they're less than 1 centimeters. So in the study, micro hemorrhage is defined as micro is defined as less than 1 centimeters, and macro is more than 1 centimeters. At the C, you can see some micro hemorrhage. And then D, you can see some hemosiderin deposits, siderosis, superficial siderosis. So again, ARIA is divided. ARIA E and ARIA H occurs slightly more often in aducanumab than lecanemab at 28% versus 17%. A few more things I'd like to tell you about ARIA. ARIA is really dose dependent. So it happens. So you start the dosing at low dose, 3 milligrams per kilogram, and then go up to 5. And then eventually it goes up to 10 milligrams per kilogram. It tends to happen at the later stages. So right now in our aducanumab trial, before we dose the high dose, we actually do check the MRI We make sure that there's no edema before we dose the high dose. And what happens, and what happens if the patient actually have edema? We just do nothing. They usually will come down. Most of them are about 80 to 90% of patients are asymptomatic. If they have symptoms, what should we look for? Most often on the right-hand side, you see that on the aducanumab patients and the lecanemab, most often headache is the most common, about 13%, about 10 to 15%. Okay, dizziness followed by that. But again, majority are asymptomatic. Okay, so we just observe them for the month, and the edema will come down, and then the next month we check the MRI, verify that there's no edema, and then we infuse again. Okay. Another thing to understand about urea is there is slightly increased risk of urea in patients who carries the E4 allele. So to remember that in Alzheimer's patient, homozygotes E4 have the highest risk. So on the diagram on the left-hand side, and you can see that patients with the E4 homozygotes have higher incidence of urea edema, especially up to 64%. Even in lecanemab patients who are E4 positive, you have 14.3% of urea edema. So checking the E4 allele, ApoE allele status is actually quite important when we do this. Okay, ready for some case study? I know that the geriatricians are so good about this. So I want to find out from you, what is lecanemab indicated for and who would not be suitable? So let's look at case number 1. So according to FDA package, Leqembi or lecanemab is indicated for the treatment of Alzheimer's disease in patients with MCI or mild dementia stage. So that is what's indicated for. In the population in which treatment was initiated in clinical trials, so which in this case is MMSE 22 and above. So that's what it's indicated for. So let's look at our first case. We have Uncle Waikiki. Uncle Waikiki is from Waikiki, 71-year-old retired Chinese engineer who has some vascular risk factors, hypertension and pre-diabetic. He is memory loss since he was about age 3 years ago, but he's still fairly active, travel, play golf, strong family history of Alzheimer's in mother and older brother. MMSE is 23, and he has homozygotes E4. And you might ask, how do you know that? Remember that we were also part of the Alzheimer's Prevention Initiative. So we actually cheek swab our patients, or the E4 allele is not covered by insurance, but you can actually get it quite easy. If you're not part of a clinical trial, you can send for 123andMe. You can ask your patients to get them quite easy. So Uncle Waikiki has E4, and the MRI noted significant small vessel disease, white matter small vessel disease. He actually even had some chronic small lacunar infarct, which is not surprising because he's hypertensive and pre-diabetic. The MRI even mentioned possible cerebral amyloid angiopathy. Is Uncle Waikiki a good candidate for lecanemab? How many say yes? And how many says no? Okay, if you say yes, I'm glad you're attending this lecture because that's exactly what we're trying to accomplish. So remember that urea happens in people in higher risk for E4. So keep in mind, so because Uncle is E4, he has higher risk for urea. Not only that, his MRI already showing some vascular changes, okay, with hypertension and pre-diabetic. And even worse, he's got cerebral amyloid angiopathy changes on the MRI. There were 3 cases of death in the lecanemab trial. One of the cases that died was actually from a patient's cerebral amyloid angiopathy. So he's actually not a good candidate because he had a high risk for urea, high risk for urea edema and urea hemorrhage. Okay, all right. So what do we do with Uncle? So remember that amyloid pathway and lecanemab is not the only thing. Okay, So other things that we do is glucose metabolism, immunity, inflammation plays a role in the vascular dysfunction in Alzheimer's disease. Remember that especially in Hawaii, there's a great population of mixed dementia or Alzheimer's disease with vascular pathology. But keep that in mind, oxidative stress, all of those. What do we do with Uncle Waikiki? So I actually put him on a different study, an NIH-funded phase 2 study called the Pioneer Study by a company called T3D or type 3 diabetes that actually works specific for metabolism bioenergetics. Okay, remember that this is probably best for Uncle Waikiki because of his vascular risk factors. This particular study tries, instead of working, concentrating on amyloid pathway, it is actually working on the vascular pathway and metabolism pathway by trying to alter the glucose metabolism. We also know that patients with Alzheimer's has abnormal glucose metabolism. So without going into too much detail. Okay, ready for the next case? Case Mr. Kona, 66-year-old retired reporter from Oregon, now lives in Kona. He travels quite a bit and just got back from a cruise with his wife. He has a history of DVT while flying. He takes Xarelto when he's traveling. No family history of Alzheimer's. His MMSE is 25. He's E2 and E3, so no E4. No E4, he's a non-carrier. MRI, obviously disproportionate atrophy. He definitely does not want to have IV infusion every 2 weeks. What should we do with Mr. Kona? Is he a good candidate for lecanemab? Even if he wants IV infusion every 2 weeks, would you put him on lecanemab? If not, why? That's because he's on Xarelto. Remember that? Okay, ARIA, hammer, patients with Xarelto. There were 2 other cases of death in lecanemab trial. The 2 other cases were patients on anticoagulants. So anybody who is on anticoagulant, probably the last people you want to put them on lecanemab. Please do not put anybody on anticoagulant on lecanemab. Okay, so Mr. Kona is a poor candidate for lecanemab because he's on Xarelto, first of all. And so what do we do with Mr. Kona? So because Mr. Kona only takes Xarelto only when he flies and not all the time, we actually put him on a different study. Remember the other pathway that attacks Alzheimer's is tau. So we actually put him on a study that works on a tau pathway, study that we call CELIA. We're Site 1030, Hawaii Memory Center, for this study that works on tau ASO, antisense oligonucleotide therapy, that binds and reduce the microtubule associated protein tau. Basically stop the translation of messenger using the messenger mRNA, stops the translation of tau. The problem with the tau products is it actually has very poor blood-brain penetration. So this product actually has to be given to Mr. Kona once every 3 months by LP. You know, you're probably asking, but he's on Xarelto. No, he doesn't take Xarelto all the time. He only takes it when he travels. We actually have to give Mr. Kona through LP once every 3 months. And he's totally okay traveling to Honolulu once every 3 months for the LP infusion of the tau ASO. Okay, ready for the next case? Auntie Kapolei. Auntie Kapolei is an 83-year-old retired Japanese teacher. She's forgetful since she was age 77 years old. Obviously, Auntie Kapolei denies having any problem. And you guys know very well, Alzheimer's patients tend to deny any problem, but they are usually brought in by their family, strong family history. MMSE is 18. Auntie Kapolei is E2, MRI, sequent diffuse cortical atrophy, medial temporal lobe. Is Auntie Kapolei a good candidate for lecanemab? Yes? No? Very good. Somebody said not indicated for later stage of dementia. Yes, I accomplished my purpose. Why? Where's the cutoff for lecanemab? 22 and above. MMSE, Auntie Kapolei has MMSE 18. Thank you. Dr. Saltman, good job. Dr. Fernandez, you have a great team right there. So what did we do with anti-Capole? So we put anti-Capole on another study that we have. It's an NIH-funded phase 2 study that looks at regulating, changing the immunity and the inflammation in the neurons and trying to recreate and synaptic plasticity, trying to grow dendrites back. I know it sounds very, but these are the things that we're doing that are really exciting. The downside to that is a sub-Q injection, sub-Q daily, but anti-Capole seems to have done well. You rotate site every day. And so that's what we did with anti-Capole, working on a different pathway. And because at this stage, we think, the neurons, the dendrites are degenerating. So it's important not just to it's important to try to do dendritic arborization, synaptogenesis at this point for patients who are later in the stage of dementia. So next, Uncle Y. Manalo. By the way, these are real cases, so that you don't think I made these cases up. I don't know if you know anybody in Waimanalo, like Uncle Waimanalo, but maybe you know him. Uncle Waimanalo is a 75-year-old retired farmer from Waimanalo, forgetful for the last 2 years. Obviously, he's brought in by his family. MMSE is 23, so he's okay. He's E3, no E4, so he's good. MRI, significant hippocampal and temporal atrophy. Here's the kicker. This is Uncle Waimanalo's word to me. I don't want anything needles. And I like you, Doc, but truthfully, I would rather go fishing and surfing than see you, Doc, every 2 weeks. That's what Uncle Waimanalo's words to me was. So what are we going to do with Uncle Waimanalo? Just remember, lecanemab has infusion every 2 weeks. What are our options? Well, I know that I'm not going to get Uncle Waimanalo to go for this option because he already told me he doesn't want to see me every 2 weeks. He want to get infusion. He doesn't want anything invasive, anything needle. They're all wanting natural stuff, Hawaiian. So I got Uncle Waimanalo to get on a different. This is a pill form, a phase 2 study that we're doing. It's called Recite 124. Indicated for patient MMSE a little bit later, 14 to 24, pill form once a day, daily pill. This butanetap is the product that we're talking about. We actually did the phase 1 study with several centers, and we published the findings in the Journal of Prevention in Alzheimer's Disease last year. We don't have time to go into the details, but if you need more information, I'm happy to share this article with you as well. Okay, our last patient, which is actually here in our Memory Center Alzheimer's Research Unit right now, right beside me, Miss Marshall Island, 67-year-old scientist working on the Marshall Island. She actually lives on the island 2 to 3 months at a time. So having every 2 weeks IV infusion out of the question. Has cognitive decline for the last 7 years, but still very, very smart, obviously, scientist. Strong family history of Alzheimer's. She's homozygote. She's heterozygote for E4, E3, E4, MMSE 27. Obviously, she has an MRI that's consistent with Alzheimer's disease. She was participated in a previous clinical trial. She's biomarker positive, amyloid positive, CSF positive for amyloid. What do you want to do with Miss Marshall Island? I hope you don't know her, but she's actually, so Miss Marshall Island, we're really excited because obviously having infusion every 2 weeks is not an option. We are actually very excited to have her in our Alzheimer's Research Unit, PK unit this week. She's going to be staying overnight tonight because we're doing a phase 1 study on an exciting product, PRX0012, doesn't have a name yet. What's exciting about PRX012? It is a novel, high affinity. Same thing, humanized immunoglobulin class 1. It's also same thing, monoclonal antibody. However, what's exciting about this product is it has 12 times the binding affinity than aducanumab. So aducanumab seems to be where everything's. So this seems to be the next generation of amyloid target that we're working on. So we think, I mean, who wants to come in to the infusion center every 2 weeks? We think that this infusion can be delivered sub-Q at home and once every 3 months. So this is what we're working on, the next generation of amyloid therapy. We're going to do some PK studies in her in a little bit after we dose her. So this is exactly what we're doing with Miss Marshall Island. So my message to the audience is I'm excited with the approval of lecanemab, but just keep in mind that amyloidosis, and it's not the everything. Okay, keep in mind there's tau, there's synaptic oxidative loss, neuroinflammation, immunity. And if you look at the pipeline in development in 2022, although 29% still works on amyloid, but keep in mind that not everybody are good patients for lecanemab. Not everybody, and think of other options for our patients. And just real quick, obviously biomarker is going to change everything that we have. In 1984, you have to see the plaque to diagnose Alzheimer's. 2011, I don't really care if we're after the biomarker and clinical syndrome. And 2018, right now, clinical spectrum is independent. We don't really care if you have memory loss or not. We are really interested in looking at biomarker. So biomarker will really change everything. Just real quick, going over primary. So all we're doing right now is tertiary prevention in patients who already have memory loss. And the clinical trials, we are working really hard to do secondary prevention, which are patients with biomarker but no memory loss. What we really need to be working on is primary prevention, to work on patients with no memory loss and no biomarker, which is where I think the future would be. This is another, just a great, I really like this map because it's the roadmap to prevention of Alzheimer's disease. Again, primary, secondary, and tertiary, working on different phases of amyloid, tau, neurodegeneration, which we don't have time to go into. What does the future look like, and what could we expect? The future looks great. In 2022, there's 143 drugs in the pipeline. 83% are disease-modifying therapy. There's 50,575 people that took part in clinical trial, in Alzheimer's clinical trial in 2022, and we're very happy that many of them are from Hawaii. We're very fortunate and very privileged and honored to be part of it. In summary, since 2019, our memory center has been collecting efficacy and safety data on lecanemab and aducanumab as part of the global research effort. Although lecanemab is approved for MCI and mild cognitive Alzheimer's, some patients are at higher risk for ARIA. Please pay attention to those. Remember to look for the E4 status. Remember to look for family history of vascular disease. Those are at high risk for ARIA, and do not use them in patients on anticoagulant. Although we have lots of work to do, the future is bright. What do I think the future is? I think the future probably we're evolving. Neurology field is, we're always following people. The neurology field is following the oncologists. I think the future people would be working on amyloid therapy, tau therapy, inflammation therapy, immunity therapy, maybe a cocktail, a combination therapy in the future. I think that's coming. Sorry, I don't have time to tell you about developing some better biomarkers, which we are working on locally with our medical student, using EEG as a widely available, non-invasive and cost-effective way. I want to acknowledge our team of neurologists and researchers that are working on with us, and also our group of medical students working on the neural network EEG project on Alzheimer's patient with us. Obviously, I'll end my talk with this patient story. I met this is Uncle William. Uncle William was very frustrated because Auntie Susan was diagnosed with Alzheimer's, and back then there wasn't much they can do. This was, and obviously Auntie Susan actually had to travel to very far away places to get care for her Alzheimer's because it wasn't available locally, and Uncle William kept asking the family, why isn't there something else that's available locally? Why isn't there more things that we can do than just watch Auntie Susan deteriorate? Obviously, Auntie Susan, passed away 15 years ago. And if Uncle William kind of looks like me, that's because Uncle William is my dad, and Auntie Susan is my mom. My mom passed away from Alzheimer's 15 years ago, and the voice of my father rings very clear in my mind. Why isn't there much that could be done for mom, and why aren't we doing more for our patients? So thank you so much for taking the time to listen to me, and also I thank you to all the geriatricians for the care that you provide daily for your patients, especially for their family, for caring for them. I applaud you for the work that you do, which are so important. You and the patients really inspire us. Please let me know if there's anything that I can do. We do need patients to be in clinical trials to develop better treatment. So I do welcome the opportunity to work with you and see your patients if you feel that they could be suitable for clinical trials. So thank you again, Dr. Fernandez. I've gone over my time.
Thank you, Dr. Liao, for a most beautiful, enlightening presentation. I want to say hats off and congratulations to the Hawaii Pacific Neuroscience Center for all the good work you're doing for the islands and helping so many of our patients get access to these novel drugs that are in the pipeline. Without your side, they wouldn't be able to get access. And I even have Kalipalama patients in your trials. So I thank you deeply from the bottom of my heart. We have many questions in the chat. We have so many attendees at this ECHO, and Dr. Morgan will facilitate our discussion from now on. There's lots of things in the chat.
All right. Yes. Thanks so much also from me for this really interesting presentation. And wow, so many sort of things going on and in our minds, I'm sure right now, questions. And just going to start with the chat, which started with Joseph Cohn from Maui. And I don't know, Joseph, you asked about targeting ARIAs and if anything cleared up your question, or if you want to go ahead and ask that now.
Excuse me. Thank you. Aloha all. My question is, I got a couple of questions, I guess, but it seems to me that Alzheimer's is a subset of dementia. And now I'm seeing that there appear to be subsets of Alzheimer's. And what's not clear to me is, and a lot of these treatments seem to be directed at symptoms or signs as opposed to actually causes. So are we still at the stage where we do not know what actually causes Alzheimer's disease? And are we actually treating the cause, or are we just treating the manifestations?
Well, thank you for the question, Joseph. And let's put it this way, Joseph. If I know the answer, I wouldn't be here today. I would be receiving my Nobel Prize in Sweden. But joking aside, for the last 20 plus years since I started training in neurology, we were treating the signs, what we call symptomatic treatment. Only more recently, I would say, in about the 10 to 15 years, we are developing therapies that we call targeting the disease or targeting the biology. So this is a disease modifying therapy. Lecanemab, aducanumab, and everything that I've talked about today, they are disease-modifying therapy. They're just not symptomatic. They target the biology. Whether it's a tau pathway, amyloid pathway, inflammation, vascular, we have not sorted that out. I got a feeling what in the future, it's going to be a combination. To tackle this problem, we need to use different therapies going forward, like the chemotherapy, you have a combination chemotherapy. Sorry for the vague answer, but I hope it's satisfactory.
Well, it's helpful, and I like to clarify, so does that mean now we're using the term Alzheimer's to include multiple different types of dementia, as
That's
in vascular and I don't know, other kinds of potential causes?
No.
Diabetic dementia, I mean, which is largely vascular, but
Okay. So dementia is an umbrella term. There are many different kinds of dementia. Alzheimer's is just a type of dementia. So you have vascular, frontotemporal, Lewy body, blah, 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 like 26 other kind of different dementia. Under Alzheimer's, we stopped calling it Alzheimer's dementia anymore. We just call it Alzheimer's disease, because you could actually have Alzheimer's disease and not have dementia. You could have Alzheimer's disease, you could have MCI and have Alzheimer's disease. You could have preclinical, pre-symptomatic Alzheimer's disease and not have dementia. So I think the proper term would be Alzheimer's disease. And that's what I've been starting to tell my patients. Well, look, you are amyloid positive, you got amyloid in your spinal fluid. You do have Alzheimer's disease. I know you're not demented. So make sure that there's the difference. Okay.
thank you.
You're
Thank you.
welcome.
Thanks for your question, Joseph. So Dr. Salman had some questions, and maybe just want to let you, Dr. Salman, go ahead and ask the questions as you have them at this time.
Yeah, thank you, Dr. Liao. It was a very interesting to hear your talk, and I appreciate it. I guess I'm interested in the sort of practical application. So this medicine was released, but it's a high bar to get it, every 2-week infusions, right? And it's kind of a high bar to qualify the way that one qualified for the study, which would be either a PET, an amyloid PET, or an LP with an LP amyloid. So I'm curious how you think that the practical application of using this medicine in the, like, who is it really for? You gave us a lot of examples of who it was not for, actually. I'm not sure that was on purpose or not. And so my main question is, who is it really for? And the other thing is, importantly, it's for early, it's for early stage disease too. And so we're in a situation where we need to identify somebody early, and it's not just mild cognitive impairment, because that could be from any number of other things besides Alzheimer's, even the 26 other dementias you mentioned. So how do we apply the inclusion criteria, and how do we, it seems to me when I read about the release, it seems, I'm sorry, I'm going on a little bit now, but it seemed like this was really for your high anxiety patient who might have identified some mild cognitive impairment, but who is, really anxious, really wants to do everything possible, even things that might have a high, inclusion bar and have a risk associated with it. They want to do everything possible to prevent progression. It seemed like the patients that were indicated for this. So what do you think from a clinical standpoint? Like, who's this drug for? How's it supposed to work? How does it work in practical terms? When I'm seeing patients in a primary care setting, one at a time kind of thing. Thank you.
Thank you, Dr. Salman. And yeah, and if you realize, I purposely presented patients that are not appropriate for a reason, keeping hopefully to send a message that just because we have one drug that's fully approved, one drug that's going to be paid for, that it doesn't answer all of the questions. Every patient's are different, and then obviously there's the economic reasons, there's the access issue, that's going to warrant a whole different hour of discussion. I think we should get Dr. Saltman to get us to do us a lecture on that. I'm certainly no expert in any way, but I do receive research funding from ASI and Biogen, so to disclose that. So, but again, I'm not afraid to speak my mind. It is not for everyone, and I think, however, for certain patients that are, it could be appropriate. It could be between no treatment and watching your loved ones deteriorate, or doing something. But you always look at, do I really want to spend every 2 weeks an hour in Dr. Liao's office, or do I want to play golf? That's the questions that the family has to answer. And and those are good questions.
Thank you. Appreciate the questions and the answer. And I just follow up on a question that I had put earlier too about, and maybe you have been speaking to this a little bit, but just to follow up further, just about the real world application and how most folks who have MCI and mild sort of Alzheimer's symptoms don't have detailed diagnostic testing, whether biomarker or MRIs or anything. And so if someone has a MSE of a 24, but they actually have vascular dementia and probably shouldn't get lecanemab, how will a primary care doctor know that?
So that's a great question. I had medical students here this morning, and we actually ran into a patient who is actually not a typical Alzheimer's, more vascular dementia. So in terms of clinical, I think by the clinical history gives you a good clue. Vascular patients tend to be more apathetic, they're more withdrawn. While Alzheimer's patient, they would try to deny. They would say that, oh yeah, I don't need to know the dates, I'm retired. That's a typical answer they give you. The vascular patient also, on the neuro exam, do a careful neuro exam with them. The reflexes are going to be jumping all over the place. They're going to have brisk reflexes, because when you looked at the MRI, they're going to have all this beautiful small vessel white matter disease periventricular lighting up like a Christmas tree. So by doing a good history, a good neurologic exam, and taking a careful look at the MRI, reviewing yourself, would actually very clearly separate vascular dementia from Alzheimer's. Keeping in mind that some patients are going to be mixed Alzheimer's disease with vascular pathology, mixed dementia. You're going to have those, but you should be able, with those 3 tools that you have, should be able to separate them quite well. And you should not put anybody with vascular dementia on lecanemab. That would not be appropriate.
So it does rely quite a bit on the knowledge and experience of the prescriber in being able to accurately separate vascular, say, from Alzheimer's through a clinical interview, which, I don't have a lot of faith that, a lot of primary care folks are vastly experienced in a broader range of things, but it's hard to ask folks to be able to do that with a lot of sort of inter-rater reliability, I guess you could say. I don't know. Just saying.
Well, I think the other thing that put in a check is, I think right now you also need to have amyloid positive to qualify for lecanemab to be covered. So in Hawaii, it will be a spinal tap, which we do every week with our patients. So if you have amyloid positive, you are amyloid positive. There's no question. Whether you have dementia, whether you are forgetful or not, you are amyloid positive. You have Alzheimer's disease. So I think that really helps. Having the amyloid biomarker also will help with that.
So you have to have that spinal tap amyloid positive marker in order to have insurance coverage for this medication. Is that
As
right?
of now, this is really
As
a
of now.
dynamic process. It changes every week. It changes every day. Now there's a registry, blah, 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 blah. It changes every week. As of now, I believe the amyloid biomarker is still a requirement, but it may change.
Thank you very much. Appreciate that. It's very, very complex and evolving, I'm sure. So Renata asked that, have anticoagulant medications been discontinued in order to start lecanemab? Or is that, Renata, do you want to add to that question or clarify?
I'm sorry, is that a question for me?
Sorry, I was going to ask Renata if she wanted to elaborate or add anything to that question. Are you there by any chance?
He asked another good question about whether there are amyloid plaques elsewhere in the body. Amyloid.
Or only in the brain. Right,
Yeah.
right. So I guess for you, Dr. Liao, is that, so number one, could you, or are there situations where you would discontinue anticoagulants in order to start lecanemab? And are there amyloid plaques elsewhere in the body or only in the brain and sort of neurons in the brain versus elsewhere?
Well, I have to say that I don't know too much about anything else besides the brain to comment on that. You guys are probably in a much better position to comment on amyloid somewhere else. But this is what I can tell you. I just had one patient that was on Xarelto. He did mention that he only takes it only when he needs to, because it's just for DVT prophylaxis, and he really wants to get on one of this anti-amyloid therapy. In this case, is aducanumab trial and vision trial. I actually advise against that because I would never want to alter whatever the patient's baseline, what's best for the patient to make them suitable for a therapy. I think that would not be the right thing. I would not recommend them going off anticoagulation to be on this therapy.
Okay, thank you. Yeah, it must be very, very specific case-by-case situations, I'm sure. So Tani Kagesa, do you want to jump in and ask a couple of the questions that you had?
Hi, thank you so much for being here today to share with us. I was wondering how we can help with advocacy to get an amyloid PET scan here in Hawaii. Like, what does that look like?
I try. Well, the challenge is obviously getting the radioactive substance here. Nobody makes them here. We had discussion with the PET facility at Queens before, but it never really panned out. It takes too long to fly the radioactive isotope to Hawaii because it will decay during the flight. The next best thing is we are sending our patients to a PET facility in Los Angeles in several of our clinical trials. For example, the clinical trial that we're working on, the next generation amyloid, you have to have a PET scan. So we actually have a contract with a facility in California to have this done. Obviously, having a PET scan is not the solution either. You got to figure out how to get it paid for. So when it's done under a clinical trial, it's covered. But when it's not done under a clinical trial, how do we do that? Please talk to the folks at Queens, the PET facility, or there's one also the PET facility at Kukini. Those are the two facilities. If you have any connection, that would be great. And we would definitely keep them busy, keep them productive. We would support them. Yeah, thank you for the great question, Dr. Kagesa.
Thank you. Not a doctor, just a social worker. Curious on how we can advocate. Mahalo.
This is important.
Okay, thanks, Sunny. A question about the contraindication of vascular disease in general for lecanemab versus, vascular dementia. Sure, that seems a lot more straightforward as contraindication, but how about vascular disease in general?
Are you talking about vascular dementia?
I think, Naomi, do you want to clarify for your question? Is that vascular disease more broadly speaking or vascular dementia?
Yeah, hi, this is Dr. Marita. So my question is for clarification. Dr. Liao had mentioned that vascular disease, that lecanemab would not be utilized in vascular disease. But my question is, vascular disease a pure contraindication to its usage, or how about in a person who has significant, who has mixed dementia with AD as well as vascular dementia, even if that person fulfills the rest of the criteria, is that still then not an indication for the lecanemab treatment?
Yeah, no, great question, Dr. Morita. I really think it depends. For example, with Uncle Waikiki, I did not recommend it because when I looked at his brain MRI, he's already at high risk for bleeding. He's already had one lacuna infarct. He had significant small vessel white matter disease, and his MRI almost looked like amyloid angiopathy, cerebral amyloid angiopathy. Plus, he's got E4, he's homozygous for E4. So he would definitely not be a candidate. However, on the other end of the spectrum, if you have somebody that has classic picture of Alzheimer's dementia with minimal small vessel disease, no lacuna infarct, no other vascular risk factors, as an E2, I guess your risks are small. Obviously the only reason that you consider that is because of ARIA. So I would say that consider the individual cases. I think it's difficult to generalize. Look at the E4 status, E4, whether they're carrier, homozygous, and look at what are the risk factors for edema and bleed. If they are already bled once, I definitely would not do it.
Yeah, I'm a little embarrassed because then I just recalled that, anyone who's got vascular dementia or vascular disease, cerebral vascular disease, that you'd want them to be either on a, some kind of antiplatelet agent or some kind of anticoagulant. So those in themselves would be a contraindication to this lecanemab. So again, I'm embarrassed at the moment.
Yeah, no, that's great questions. They are often on antiplatelets, anticoagulants, and that's difficult. Yes.
Thank you so much.
No worries, Dr. Marita. I think all of this discussion is clarifying for all of us for sure. And just a couple minutes left, so I wanted to just point out that Michaela posted a link for folks seeking CMEs, and so there's a link in the chat box there. So definitely click on that or check that out as time is running out here. So just wanted to really thank everybody again for all your awesome questions. I know we didn't get to every single one of them, and just thanks so much, Dr. Liao, for joining us today and sharing this really, really fascinating stuff with us. Dr. Liao just posted for research referral for, his number and email are there in the chat as well. So, and that's where folks would contact you for referral to sort of participate, their patients and things like that. Is that right?
Yes. Thank you so much for the opportunity, for the honor and privilege to present today. Thank you, Dr. Morgan, Dr. Fernandez, and it will be our pleasure to see the referral and serve your patient.
Okay, gang. Well, time is almost out, and we appreciate everyone's attendance today, and really appreciate the engagement and the discussion. So, hope everyone has a wonderful rest of your week. Aloha.
Hello, Dr. Leo. Thank you so much. You are a trailblazer, as the comments are in the chat. Thank you for gracing us with your presence today.
Oh, no, I'm just following your example, Dr. Fernandez. You are my hero.
No,
Working
not at all.
at KKV, it is our honor and privilege to serve your patient. You are my hero, Dr. Fernandez.
You're too kind. Well, everybody, please send referrals to the Hawaii Pacific Neurosciences Center. It's a great opportunity to serve the people in Hawaii on these new pipeline medications. Mahalo. Enjoy the rest of your day.
Thank you.